Hey everyone, this is Morgan. I'm going to be doing some of the lectures for the men's health course, and today we'll start off by talking about androgens and anti-androgens. So androgens are the first part that we'll focus on, and this is primarily going to be testosterone that you think about. So first we'll talk about low levels, which is hypogonadism in adult males. So this would be related to a decrease in sperm or testosterone production. And of note, testosterone does decrease with age. So this could be referred to as late onset hypogonadism in patients who are older. And then there can be primary or secondary hypogonadism, with primary also being associated with high luteinizing hormone or follicle stimulating hormone levels, and then secondary being associated with low to normal LH and FSH levels. You may also hear low testosterone referred to as low T. So hypogonadism, this is just a more physiologic type of diagram that we're looking at here. So the hypothalamus will release gonadotropin releasing hormone, which goes to the pituitary gland to signal for luteinizing hormone and follicle stimulating hormone release, which then in turn goes to the testes to result in production of testosterone or sperm. And with this, there can be a negative feedback loop associated as well, which can explain why we see differing levels of luteinizing hormone or follicle stimulating hormone based on the type of hypoaldosteronism that they have. So FSH goes to the Sertoli cells to produce sperm, and then luteinizing hormone will go to the Leydig cells to also produce sperm. And then in turn, these hormones will go back up to the hypothalamus and anterior pituitary gland to inhibit the production and release of FSH and LH. So this is how we can see lowered levels of these being produced. So testosterone and low testosterone are going to be associated with some different symptoms. So testosterone is responsible for various functions such as facial and body hair production, libido, some different feelings of moods, and then also sperm production, erectile function, muscle mass and strength, and then also bone mineral density. So patients may present complaining of some various symptoms that could be related to these different functions. So these patients can present with physical effects such as loss of body hair, reduced libido or impotence. They may have reduced energy levels, muscle mass, increased body fat. They may also have some decreased motivation, self-consciousness, feelings of sadness or depression, some sleep disturbances, but then also poor concentration or memory. So for treatment of low testosterone, the goal is to restore normal levels of T and also improve their symptoms of low testosterone. So some monitoring when we have a patient on treatment is going to include obtaining testosterone levels 3 to 6 months after starting therapy, hematocrit and hemoglobin levels through a CBC, liver function test through a CMP, bone mineral density, especially in men who have a history of osteoporosis or fracture, and then also blood pressure. And this is related to hypertension that may occur with testosterone replacement. For adverse effects, the more common things that we would expect to see include things like swelling or edema, hypertension, local irritation related to the product that they're using, erythrocytosis, which may also increase their risk of cardiovascular events, and then all-cause mortality, hepatic effects. So this will be while we're monitoring their liver function test or their bilirubin levels, thromboembolisms, and then also aggression or mood disturbances. There's also some debatable data on the cardiovascular risk, but I think it's important that we keep this in mind in patients who maybe are already at an increased risk of a cardiovascular event, that maybe this wouldn't be the most appropriate patient to treat for low testosterone. Also, there's questionable, but also related to the mechanism of testosterone naturally occurring in the body, that there can be elevated risk of prostate cancer or BPH due to the growth that can occur in the prostate. Testosterone contraindications include breast cancer in males, prostate cancer, and then also any patients who are pregnant or planning to become pregnant if they're female, and then also hypersensitivity to any product component. Testosterone does have a risk of abuse and diversion because it can be easily obtained sometimes by patients who it has not been prescribed for, and it is considered a C3 or Schedule 3 controlled substance. There is a risk of dependence with testosterone, and then also it is teratogenic, so pregnancy category X, so any exposure to females can put them at risk. So it's also important that patients know to avoid any exposure to females prior to washing their hands if they're using a product such as the gel, for example. The first product that we'll talk about are the intramuscular injections for testosterone replacement. This includes the Nanthate or Cypionate product that would be given every 2 to 4 weeks, or the Andecanoate, which is given once, followed by a dose 4 weeks later, and then every 10 weeks after that. So could be given a lot less frequently after the initial 2 doses. These are going to be administered in the buttock muscles, and then it's important that they are not given intravascularly due to the risk of pulmonary oil microembolism. So most of these injections are going to be given in office. The Andecanoate product does have a black box warning for those pulmonary oil microembolism, and then the cost can vary based on the formulation that's being given, also the dose, and it is important to keep in mind that some patients also will not receive any coverage from their insurance, so some of these can be expensive out of pocket for patients. There's also the transdermal gel. So the most common brand name that you hear of is Androgen. And so this can come in some different percentages, whether it's 1.62%, or 2% gels. And the dosing can vary based on the number of pumps being used. So these can have some guidance based on that. For example, the Fortesta gel, you have to use 4 pumps to equal their dose, versus Androgel, you can use anywhere from 1 to 4 pumps to equal the dose. They will be applied in the morning to the shoulder and upper arms. The 1% Androgel can be applied to the abdomen, and the Fortesta can be applied to the thighs, or if it's the solution, to the axillary region. It is important to wash hands after application due to that risk of secondary exposure for females. And then the alcohol-based gels are flammable, so it's always important to note that patients need to know. They also making sure that they know that there may be multiple pumps involved. And then it's always good to check the package insert for these products, or a site such as Lexicomp, to determine any specific things that may be associated with the product, as well as the recommended dosing. There are some generics available for the various testosterone products, which can sometimes help with cost, but overall the cost can still vary, but typically running less than $25 a month. For the transdermal patch, this is going to be applied onto the skin daily. So starting at 4 milligrams daily, and then can be adjusted based on their serum testosterone levels. It's important to apply this at the same time every night to the back, abdomen, upper arms, or thigh, and then rotate the application sites. It's important to avoid showering or swimming for over 3 hours when the patch is applied, and then also take off prior to MRIs. Sometimes some different formulations can have magnets in them, or something that can be attracted to a magnet, or some type of metal in it. So just keeping that in mind. Additionally, the adhesive can sometimes be irritating, so patients can use a topical hydrocortisone cream to help with that irritation or try to prevent that. These patches do come in a 2 and a 4 milligram patch, but they cannot be combined with the 2 milligram to equal a 4 milligram, for example. And then there are some different formulations that don't fall into the other categories, such as the subcutaneous auto-injector given weekly, or the implanted pellet given every 3 to 6 months. Of note, the auto-injector would be applied to the abdomen. The pellet would actually be surgically implanted, but it's an in-office procedure. So that pellet is about the size of a dime and would be entered into the upper or the outer quadrant of the hip or gluteus. And then the nasal gel, which would be given 3 times a day. It's important to blow your nose prior to administration of that medication, and then also direct it towards the back of the nose. And then the oral capsule, that would be given twice a day with a meal, and then can be adjusted based on those testosterone levels as well. So now let's switch roles and talk about the anti-androgens. So the anti-androgens are going to be used for treatment of BPH, or benign prostate hyperplasia, which we will have more detail about that in a separate lecture. But these, we may see the 5-alpha reductase inhibitors used again in the prostate cancer prevention. We may see some use of the 5-alpha reductase inhibitors there. And then for prostate cancer treatment, we can see our gonadotropin releasing hormone agonist or antagonist, along with the anti-androgens. So the way that 5-alpha reductase inhibitors work is that 5-alpha reductase is actually the rate-limiting step in breakdown of testosterone to dihydrotestosterone. So with this and the breakdown of testosterone, we can have increased prostate growth, and then also some hair loss. So when we give these agents, we can have reduced levels of the prostatic hyperplasia, but then also alopecia. So that's another place we may see these agents used, is in patients who are experiencing hair loss related to testosterone. So the 5-alpha reductase inhibitors will reduce the size of the prostate gland to improve urinary flow. They do take a while to work, so keeping in mind that patients are not really going to see a result from these for 6 to 12 months after starting therapy. We may see these indicated, however, if there's an enlarged prostate that's greater than 30 cc on imaging, if it's palpable on a rectal exam, or if they have a prostate-specific antigen or PSA level that's at least 1.5 or greater. And then they're sometimes used in combination with the alpha blocker. So the different 5-alpha reductase inhibitors include finasteride or Proscar, and dutasteride, which is Avodart. So the finasteride is going to be used alone or with an alpha-1 blocker, while dutasteride is going to be used alone or with tamsulosin. And then finasteride would be dosed at 5 milligrams once a day, while dutasteride would be dosed at 0.5 milligrams a day. So coming back to a similar diagram to what we saw earlier with the hypothalamus and the gonadotropin releasing hormone causing the release of inhibin and then sperm production from the Sertoli cells and then the Leydig cells to produce testosterone with the negative feedback here. So the gonadotropin releasing hormone agonist and antagonist will work in these different diagrams. So as we remember, the hypothalamus will release gonadotropin releasing hormone to go and stimulate the pituitary gland to produce the FSH and LH, which goes then to the testes to produce testosterone. So when we give a GnRH agonist, our goal is to actually target this negative feedback loop that we talked about earlier here. So as you can see, when we have the production of testosterone, it's actually going to feed back into the hypothalamus through that negative feedback loop until it to stop producing the GnRH and releasing that into the pituitary gland. And then on the flip side of that, we have the gonadotropin releasing hormone antagonist, which goes ahead and stops GnRH right here versus having to go through the negative feedback loop to inhibit the production. Then we have direct inhibition through the antagonist versus the agonist, which is going to stimulate the growth. So GnRH agonist and antagonist, we're going to have some monitoring similar to what we saw prior, including the serum testosterone levels, bone mineral density, but then here as well, serum glucose levels, and then prostate-specific antigen. Some adverse effects of these include a tumor flare that's associated with the agonist, and that's because if we're stimulating the production of LH and FSH to produce that testosterone from the testes, then there's going to be an initial increase before that negative feedback loop takes effect. We can also see some hot flashes, decreased libido, gynecomastia, fatigue, decreased bone mineral density, and diabetes associated with these agents. And that's just due to the lack of testosterone that is present with these agents. The GnRH agonist and antagonist include leuprolide, which is an agonist, goserelin, which is an agonist, and then degarelix, which is an antagonist. And each of these are going to be given through an injection, with leuprolide being an intramuscular or sub-Q injection that's given every 1 to 6 months. That can depend on the dose that's given. And then goserelin, which is a sub-Q implant given every 1 or 3 months. And then degarelix, which is given every 28 days. Some other anti-androgen agents include enzalutamide, bicalutamide, darolutamide, apalutamide, or abiraterone, which is slightly different from the other agents that were listed above. And so these will interfere with dihydroxytestosterone or DHT binding to its receptor. So these are indicated in prostate cancer, either as monotherapy or in that combination with GnRH agents. And then additionally, that testosterone flare, we may see them given just temporarily with the GnRH to prevent that from occurring. These do have a lot of drug interactions associated with them, so it's always important that a drug interaction check is ran when starting one of these agents or starting new medications in a patient who is on one of these agents. All right, so that wraps up our androgens and anti-androgens discussion. Thank you all for listening in.